Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Galderma.
Hello, I'm Dr. Gil Josipovich. I'm a professor of dermatology and the Stiefel and Doe Chair of Medical Dermatology and the director of the Miami Itch Center at the University of Miami Miller School of Medicine. Welcome to this Medscape program titled The Itch Factor, Troublesome Symptoms and Dermatological Conditions. Our program agenda includes the following. In Chapter 1, I'll discuss the pathophysiology of itch and atopic dermatitis and prurigo nodularis. In Chapter 2, Dr. Jonathan Silverberg and Dr. Linda Stein-Gold will discuss addressing itch and atopic dermatitis. And in Chapter 3, I'll return with Dr. Sean Quatra and we'll discuss understanding prurigo nodularis and its management. In this chapter, I'm going to review the pathophysiology of itch and atopic dermatitis and prurigo nodularis. Let's start by looking at the clinical burden of itch in patients with AD and PN. So in AD, we all know that there's significant itching. There are also flares of a disease. I want to also mention that there's a pain component with the itching in many cases. There are comorbidities associated with this disease, as you well know. Patients can have asthma, allergic rhinitis. There's also, with the itching and scratching and the damage to the barrier, risk of infection, especially staph. It actually activates and aggravates the itch in these patients. This also leads to a lot of aspects of loss of sleep. Patients, especially kids, it has an effect on their school and adults on work. It also leads to a lot of aspects of mental health, depression, anxiety, and loss of self-esteem. And clearly, this also aggravates more sleep abnormalities and it causes a vicious circle. Let's discuss a bit the burden of PN. In PN, basically, the major problem is really patients itching and scratching themselves. This leads to significant sleep disturbances due to the itch. Remember that these patients also have nodules that they develop out of these itching and scratching. It causes a significant also psychosocial disturbance, again causing anxiety, depression, and this also amplifies that itch scratch cycle. Our next shows a study we've conducted on sleep disturbances in both these populations. This is from a single center. We have an itch center, and we looked at atopic dermatitis versus PN, and very similar effect on sleep. The majority of the patients, more than 60% of these patients, had a significant impact of this disease and the itch on their sleep. I'd like to discuss a bit the pathophysiology and the mechanisms of itch. And I wanted to kind of share with you first an understanding of the narrow component of itch. We know that itch is emanating from the skin, and you have to have nerves. These nerves are transmitting itch. Usually in chronic itch, it's a non-histaminergic pathway, suggesting that antihistamine, that's why antihistamines don't actually work for chronic itch and atopic dermatitis and PN. This involves then the nerves going into the dorsal root ganglia. From there, they go up to the spinal cord. We then go up to the brain, and also the brain sends signals downstream and it can inhibit the itch by scratching and other methods. I mentioned down below there are neuropeptides involved both in the periphery as well in the central nervous system. I'd like a bit to delve into the pathophysiology of atopic dermatitis itch. And in this case, we know that there are three different components. One is significant damage to the barrier and keratinocytes, and they send signals via some chemokines and neuropeptides to induce itch. There is also significant immune activation and dysregulation, in particularly type 2 cytokines such as IL-4/13 and IL-31. In addition, the nerves are overactivated in this condition, and there's actually a reduction of number of nerves in the epidermis, but the nerves are very activated. There are also some other mm, key cells involved, including T cells and macrophages. And clearly, this all induces itch and scratch cycle. Let's go to our next slide that describes the pathophysiology of itch and prurigo nodularis. So here there are a lot of similarities to the pathophysiology in atopic dermatitis. Again, there's a immune dysregulation with a high expression of type 2 cytokines such as IL-4/13 and IL-31. There's also significant neurosensitization of causing that the nerves are overactivated. The difference between atopic dermatitis itch and PN itch is that the epidermis is a very key factor in atopic dermatitis. In a PN, there are secondary damages from scratching the skin, but the pathophysiology is mainly in the dermal epidermal area. There's a significant importance of macrophages and also fibroblasts. We all see that nodular lesions that you won't see in a classical atopic dermatitis patients. And again, in this slide, I mentioned that the importance of scratching and picking on the skin causing the inflammation in PN, and this activates also the neural component, causing neurosensitization. This further amplifies that itch scratch cycle. I would like to mention another key factor in itch in prurigo nodularis. This is an extracellular matrix protein called periostein. It's secreted by fibroblasts and keratinocytes, and our group has found that this is a important protein in the association with itch intensity. It can activate the fibroblasts to secrete more type 2 cytokines such as IL-13 and IL-4, but it also has, interestingly, a direct effect on the nerves via its activation of integrin alpha beta receptor. Of note, also periostein is highly expressed in atopic dermatitis and other condition where there's type 2 cytokines. But in PN, its role is very robust. So, in summary, what I discussed today is that atopic dermatitis and prurigo nodularis both are itchy inflammatory dermatosis associated with a complex interaction between the immune type 2 cytokines and neural system. The hallmark, again, is important to understand is that type 2 inflammation with particularly IL-4/13 and IL-31 is common in both conditions. AD is highly associated with barrier abnormalities and crosstalk between keratinocytes, immune, and neural cells, while in PN, the association is with a dermal inflammation and crosstalk between dermal macrophages, fibroblasts, and immune and neural cells. Clearly, neuroimmune activity is a target for effective therapies for both conditions. Thank you for watching, and in the next chapter, Dr. Jonathan Silverberg and Dr. Linda Stein-Gold will review the treatment of itch and atopic dermatitis.
Hello, I'm Dr. Jonathan Silverberg, professor of dermatology and director of clinical research and patch testing at the George Washington University School of Medicine and Health Sciences. Welcome to this chapter titled Addressing Itch in Atopic Dermatitis. I'm pleased to be joined today by Dr. Linda Stein-Gold, who is director of dermatology research and division head of dermatology at the Henry Ford Health System in Detroit, Michigan. Welcome, Linda.
Thrilled to be here. Thanks for having me.
In this chapter, we'll be discussing the following: assessing itch and atopic dermatitis. We'll be addressing data on itch relief from clinical studies of atopic dermatitis treatments for a variety of topicals, biologics, and oral JAK inhibitors, as well as tips for clinical practice. Let's start our conversation by looking at how we assess itch in clinical practice for our patients with atopic dermatitis. So, itch is a complicated symptom. It's one that really has a variable presentation, variable intensity, variable persistence. So this is a study that my group actually conducted, looking at just trying to partition and define different clinical phenotypes of patients with atopic dermatitis based on combinations of the severity of their itch versus the severity of their lesions. And so we have mild to moderate itch, mild to moderate lesions, severe itch, severe lesions, and mild to moderate of one and severe of the other. And what we found was that about 1 in 4 adults with atopic dermatitis in the dermatology practice setting had this severe itch but mild to moderate lesions, what we call the itch-dominant atopic dermatitis. And this patient group had a poor prognosis. They weren't quite as bad as those who had severe itch and severe lesions, but they were a lot worse than those who just had mild itch and mild lesions. So it's something that we need to be aware of, that if we're not assessing itch on a routine basis, that we're going to be missing a large subset of patients who are ultimately having poor control of their disease and will ultimately need to be advanced to more advanced therapies. Linda, how do you assess itch in your patients with atopic dermatitis?
First of all, I try to do it with every patient at every visit because, as you mentioned, it's critically important, and I don't think it has to take that much time. So I often just use the basic from 0 to 10. Tell me, how bad is your itch? How bad has it been for the past few days? I often ask also, is this affecting the way you sleep? But this way, if I ask about it at each visit, I can really monitor how well I'm getting the itch under control.
Absolutely. And I think, my experience has been pretty similar. I feel that, I really like to routinely asking a single NRS itch, as you're describing, takes 10 seconds. And it's such rich information and worth documenting in every patient. Now let's shift gears and look at some medications that can be used to control itch in patients with atopic dermatitis. Linda, can you start us off with some topical medications?
Absolutely. We've had this wealth of new medications in the nonsteroidal topical arena for atopic dermatitis. We've seen ruxolitinib cream, which is a topical JAK1/2 inhibitor that's FDA approved for patients age 12 and up. Delgocitinib cream, not yet FDA approved. We have tapinarof cream. This is a novel mechanism of action. This is a topical oral hydrocarbon receptor agonist. And then we have roflumilast cream, which is a topical phosphodiesterase type 4 inhibitor, but it's much more potent than the other PDE4 inhibitors that we've used in dermatology. So taking a look at some of the data, we'll start with ruxolitinib, and this is a topical JAK. And as we would expect from a JAK inhibitor, we see very rapid onset of the itch reduction. We see really, really quickly those patients start to get control. We saw similar results with both clinical trials. In fact, with one study that was an open label study done in adults, we found that itch actually starts to decrease as early as about 15 minutes. So we do see some good results with this topical JAK inhibitor. Looking at the next one, which is not yet FDA approved, delgocitinib. This has been studied for chronic hand eczema, and the itch, even for chronic hand eczema, is really critical for these patients. And again, as a topical JAK, this is a pan-JAK inhibitor. We start to see onset very rapidly, nice separation from the vehicle, and this improvement in itch is actually stable over the course of a long-term study that was an additional 36 weeks. So that's nice to see. Looking at these other non-steroidals, we have to ask, are we really going to see a reduction if it's not a steroid? And again, with tapinarof, we saw a nice reduction in itch. When we look at that 4-point reduction in worst itch, we see that almost half of those patients got it by week 8. But also when we look day to day over the course of the first 14 days, we start to see a reduction by day 1, and that's actually separates out more nicely by day 2, and we see rapid reduction over the course of 2 weeks. So that's really good news. And then finally, We have roflumilast cream, again, a topical phosphodiesterase type 4 inhibitor. These drugs are all compared to their vehicles, and a lot of these vehicles are quite nice. We see some reduction with the vehicle, but of course, we see a much more rapid and complete reduction with the active drug. And we see that with roflumilast again within the first few days, nice separation from vehicle, and that continues over the course of the study. So, good news is a lot of great treatment options in the topical arena.
Yeah, I think these therapies really are such an important innovation and in addition to our toolbox now. And it really gives us so much more to play with than we really had in the past.
I agree. And one of the issues in the past when we talked about the nonsteroidals is we had that tolerability issue. When we used them, they worked, maybe not great, but they did work, but we had to deal with the stinging and burning. And I think with these newer nonsteroidal topicals, that's not an issue. These tend to be really well tolerated, even when you use them in sensitive areas.
Yeah. And any safety or tolerability concerns? Well, you mentioned the tolerability, but additionally, like safety issues that we need to think about with these topicals?
Yeah, these are again, they're topical. There's minimal systemic absorption with the topical Jack that's FDA approved. We want to keep a minimum body surface area. We don't want to go above the 20%. We don't want to use it chronically. It's really for short term and non-continuous long term. But in terms of in general, I feel that these drugs are really very, very safe. So let's switch gears, Jonathan. There's so much in the biologic world, so much going on. Can you give us an update on what's going on at Itch?
Sure. Yeah, we don't have enough time to address all the data that are out there. The reality is there's so much now. And in truth, all of the biologics that are approved have been shown to work on a variety of different, metrics of itch. And so we're quite fortunate. But there's nuance there, and there definitely are potential differences in terms of either the onset of response in itch or the level of degree of potency in terms of itch, et cetera. So let's start first. I guess we can discuss with nemolizumab. It's really the newest kid on the block that was just approved for moderate to severe atopic dermatitis, and we've always sort of had this on our radar, at least not always, but at least for the past few years, because mechanistically, we know that IL-31 plays an incredibly important role in directly binding to receptors on peripheral nerves and directly triggering action potentials for itch. So it's a really cool sort of bridge between the immune system and itch as a symptom in this disease. And so nemolizumab is binding to the interleukin-31 receptor alpha subunit, which is part of that heterodimer complex responsible for the signaling of IL-31. So if you block it, in theory, you should be blocking the itch. Now, it turns out IL-31 does a lot of other things too, in terms of barrier function and pro-inflammatory effects, et cetera. But we think that the dominant effect of this cytokine and its blockade will be on the area of itch. Now, when we look at the data, and there's a lot more data to look at, but if we focus specifically on itch as an endpoint, and we look at 4-point improvements of itch, which is now, the FDA's sort of preferred way of looking at this, how many patients got a 4-point reduction in their worst itch on average over it's a 24-hour recall period, but over a 7-day average of those 24-hour periods. And what we see is already statistical significance that's happening by week 1, already even earlier when you look at the breakdown of day by day. And the efficacy on itch just continues to improve beyond week 1 out to week 2, week 4, and with no evidence of a plateau even at week 16, indicating that there's potentially more efficacy to be gained beyond that. Now, what's interesting is when you look at the subset of patients who have severe itch at baseline, we see potentially even more efficacy there. And so it's rare that you see a drug be more effective in a more severe patient population, but because of the importance of itch in these patients and the primary role of IL-31 in itch, what seems to be some of the greatest efficacy for this drug are those who really have that severe itch at baseline. And when we look at other ways of examining itch, one would be just first long-term after week 16. If they did well, they were re-randomized to get either continuous Q4 week dosing or a spread out Q8 week maintenance dose or placebo. What we see is a nice maintenance of response for the 4-point reduction in itch all the way out to week 48 with all of the doses, although the every 2 week or every 4 week dose work the best with longer term treatment. But when we look even at those proportion of patients who can get to what we may call itch free or minimal itch, an NRS itch score of less than 2, a really very high degree of maintenance of that, whether with continuous Q4-week dosing or Q8-week dosing. And I think that on the more robust levels of control of itch, like getting to an NRS itch of less than 2, is where we see some of the greatest efficacy. We've also seen efficacy and maintenance of responses out to week 48 for sleep disturbances and improvements of sleep, quality of life disturbances improving as well. So holistically, this drug is working across a variety of different endpoints. Now, when we look at some of the other targets, sort of the oldies, if you will, where we've got dupilumab as the first approved biologic hitting the IL-4 receptor alpha subunit, blocking signaling of IL-4 and 13. Lebrikizumab and tralokinumab came afterwards, blocking the free IL-13 cytokine. What we see is really for all of them, a good demonstrated efficacy across the clinical trials. And so when we look specifically at dupilumab, there's an extraordinary amount of data there that have been published across a variety of different trials. But when we look at, post hoc, the data pooled across these solo trials and across the adolescent trials, what we see is really nice responses. And even with dupilumab, significant increases in the proportion of patients who can get 4-point reductions in itch. So for this, if you look at, depends on which endpoint you look at on which trial, but either day 2 or day 3, there's already significant improvements demonstrated there. And likewise, when we look at tralokinumab, even though when we look at some of the other endpoints where we think maybe tralokinumab might be a little bit slower than dupilumab, but even here we can see as early as day 1 or 2, significant reductions in itch when you're just looking at mean changes in the worst itch scores. And that efficacy continues to widen out to week 2 and beyond. And we look at lebrikizumab as well. We see, good responses out to week 16, but, early responses as well demonstrated in 4-point reduction in itch, either as early as week 2 or week 4, depending on which trials you're looking at there as well. So I think the reality is all of these drugs work on itch. I wish I had a crystal ball to be able to predict like who's going to be like that super responder on one versus the other. And there's a little bit of a trial and error process there, but I think there's something for everyone now. And so, and certainly then on top of that, we have all the JAK inhibitors. What's been your experience, Linda, with all of the different therapies and with the JAK inhibitors?
I agree with you, Jonathan. We have so many great treatments, and itch is getting under better control than we've ever seen before. And that was such a nice overview of what we see with the biologics. When we look at the JAKs, we know that JAKs works really, really well in terms of itch. Looking at this first study, looking at abrocitinib, we know it comes in 2 different doses, especially the 200 milligram dose, really, really rapid onset of response. With patients on a JAK inhibitor, really, they notice that fairly rapidly within the first few days even, and even the 100 milligram. And then we see that dupilumab pretty much catches off over the course of time. And then looking at upadacitinib, again, this was studied head-to-head with dupilumab. And again, upadacitinib kicks in very, very rapidly within the first few days, definitely within the first few weeks, in getting that itch under control. Dupilumab does start to catch up as we head out farther on, but these drugs work exceptionally well.
Yeah, it's really impressive to see, and I think the speed of the JAK inhibitors is something that we've noted across a number of trials right now. So it's really great to have all these different options. So Linda, do we see the same safety profile though with the JAK inhibitors versus the biologics, or is this a completely different ballpark?
It's a little bit of a different ballpark. Yeah, I think so. We know with the biologic drugs, these are exceptionally safe drugs. We don't really require any blood monitoring. With the JAK inhibitors, we do have to, do some monitoring, but long-term studies have really shown that these drugs are very safe. And when used appropriately, these are revolutionary for our patients.
There's so much here. I think the biggest challenge that we face right now is how do you sort of decide between them in the real world, and that we don't have enough time to cover. But I think just, in the remaining time, maybe we can just discuss a little bit about practical tips for controlling itch in our patients. And I think first and foremost, I'm happy to kick this off. I would say what we mentioned already, you've got to ask. Because if you don't ask, you're going to totally miss the boat that their itch is not controlled, and this is an important therapeutic target. And ask for at every visit. So this way you can track their progress with specific treatments. And I think sometimes you have to use combination therapies, whether that's adding on a topical on top of a biologic, maybe even combination therapies, even though if technically that might be off-label, but sometimes that's needed because the patients may be doing okay with one of these newer therapies, but just still not optimally controlled.
Yeah, I agree with you. And I think we now have so many tools. We really owe it to ourselves and to our patients to just get educated on them. We really want to make sure that we're comfortable with the topicals, with the biologics, with the orals, to make sure that our patients have the medications that they need.
Absolutely. Well, Linda, this has been a great discussion. Thank you for joining me today.
It's my pleasure.
And thank you for watching. In the next chapter, Drs. Josipovic and Quattro will discuss medications for controlling itch in patients with prurigo nodularis.
Hello, I'm Dr. Sean Quatra. I'm the Joseph W. Burnett Professor and Chair in Dermatology at the University of Maryland School of Medicine. Welcome to this chapter titled Understanding Prurigo Nodularis. I'm very pleased to be joined by my friend and mentor and colleague and world leader, Dr. Gil Josipovic, who's a professor of dermatology and the Stifel Endowed Chair of Medical Dermatology at the University of Miami School of Medicine. Really just a world leader setting the tone for itch. So welcome, Gil. I couldn't think of a better person to be doing this program and this chapter today with.
Pleasure, Sean.
Absolutely. So the agenda for today, in this chapter, we will discuss the following key concepts: the pathophysiology of itch and prurigo nodularis, what we know right now, what's emerging. Also treatments for prurigo nodularis. So we can talk about traditional immunosuppressants, the revolution that's going on in targeted systemic therapies and biologics and neuromodulators, and also help to provide some tips for clinical practice. So Gil, can you get us started by reviewing the pathophysiologic mechanisms of itch and PN? So this will be pretty relevant for our treatment discussion that's to follow.
Yes, so prurigo nodularis is a unique neuroimmune and inflammatory skin disease, and it is actually distinct molecularly and clinically from other common conditions like atopic dermatitis or psoriasis. And the similarities to atopic eczema is that type 2 cytokines are key factors in P and pathogenesis, and there is a very significant crosstalk between the immune cells and the neurons that can cause a positive feedback loop exacerbating the disease. The more the patient picks and scratch, the more itch, and it's a vicious circle. Another important aspect of this disease that is different from a disease like atopic eczema is that there's a significant role of fibroblasts in the pathophysiology. And in this slide, what we could see is where the targets of several of the drugs and the targeted treatments that have been developed for this condition, particularly dupilumab and nemolizumab. Dupilumab targets the IL-4/13 pathway, and nemolizumab targets the IL-31 receptor. I would like to mention that there are other key players in this condition. There's a lot of significant activity of macrophages, mast cells, and the majority of pathophysiology is actually located in the dermal area. And this is a bit different from atopic eczema, where the epidermal component is very strong.
Absolutely. Thank you, Gil, for that great overview. And I agree, the biology and pathophysiology here is so elegant with the nerves and the neurons in such close contact with the immune cells and the cytokines. And I think that was such a great overview that helps us turn our attention, which you alluded to treatments for PN. I don't think we would have believed it, but we now have two biologics that are approved for prurigo nodularis, both dupilumab and nemolizumab, which is absolutely incredible for a disease that wasn't on the map just a very short time ago. So, Gil, you can take the lead and walk us through a little bit with dupilumab.
Yes, so dupilumab was approved in 2022 for adult patients with PN. It has a similar dose of such as in atopic eczema, a loading dose of 600 milligrams, so 2 injections of 300, and then followed every 2 weeks by 300 milligrams. And nemolizumab was approved just last year for adult patients with PN. And here there's some weight-based dosing, monthly injections via pre-filled pen, or it's 30 milligram per injection or 60 milligrams based on weight. If patients are obese, they need a higher dose. We'll start with dupilumab. This is the pivotal study that led to the approval by FDA of dupilumab for PN, the PRIME and PRIME 2. What we could see here is that there's significant itch reduction, which is a meaningful itch reduction is considered of a worst itch NRS of improvement of 4 or above, as well as total lesion clearance at week 24. Both studies have had quite a similar response, both on the itch between 60 to 57%, and also in the lesions themselves as a 48% and 44% patient achieving a 0 and 1, mainly clearing of condition. And the next slide shows that the reduction of itch through week 24, and what you could see here that the reduction starts quite early in the first month, and it continues to be reduced in both studies. So impressive results of a drug that works for PN. What about the safety profile of dupilumab? And it's not surprising. We all know that dupilumab is a rather safe drug due to our experience with patients with atopic eczema. Of note, conjunctivitis that is quite common among patients with atopic eczema. It's quite rare to see in PN. Remember, the majority of PN patients do not have active atopic eczema. Other adverse effects, very minimal, so an excellent safety profile. So, Sean, this is now your chance to share with us the pivotal data of nemolizumab that you were a primary investigator.
Thank you, Gil. That was just a wonderful overview of the dupilumab in prurigo nodularis, and really was a trailblazer in the work you spearheaded, and that we have for dupilumab. And nemolizumab now is our second approved agent. And as you can see here, you also had similarly about almost 60% of patients that have that 4-point improvement in itch. And you can also see similar improvements in sleep, and then the nodules and lesions from the Olympia 2 trial, up around 30 to 40% there by week 16. But what's really unique, I think, an element of nemolizumab is if you look at the curve and the speed and the slope of improvement in itch, which has also, I think, been apparent in clinical practice now that the drug's approved, seems to be acting very fast and very much so mirrored by the improvements in sleep. So if we look a little bit more closely at the Olympia 2 trial, Olympia 1 had extremely similar data as well. You can see that after the first injection, this is a Q4 week therapy, already over 40% of patients had that 4-point improvement in itch. And this just continues to increase, does not plateau as well. And so again, similar results to Olympia 1, and then long-term data is also showing the majority of patients are reaching significant improvements in itch and also improvements in skin lesions as well. So if we look at safety profile, pretty safe, no regular lab monitoring that you need. Overall, some things that you may consider is that a minority of patients can develop an eczematous dermatitis, a small proportion of patients with headache or peripheral edema, but largely very safe, no lab monitoring, anything like that in that Q4 week injection therapy. So Gil, we now have 2 agents. We wouldn't have believed it, right? Just a few years ago. I think it's made our practice so much easier, don't you think? What do you think?
100%. I mean, it's a different ball game. I mean, our patients were so miserable before because none of the treatments, and including immunosuppressants that we were using, were not effective. And now we have really good targeted treatments with
rapid effect. So very exciting times.
And safe, because a lot of these
Right.
patients have comorbidities, and so we usually would worry a lot, but these are great. They don't have any liver comorbidities, any kidney comorbidities, or adverse events. So that's I know it always reassures me in clinic to know that these are safe in patients with a lot of disease comorbidities. So why don't we think about other treatment options that we have for PN? So Gil, if you want to start with some of the locally acting agents.
Okay, so I think all of us have tried topical steroids with different potencies. High potency steroids usually are used for PN, but they're very limited. I would say that intralesional injections, they are maybe fit for if a patient with PN has just a couple of lesions, but the majority of the patients we see have PN that is more extensive than just 1, 2, 3 lesions. So the practicality of using the topical steroids are very limited. We've used before, and sometimes I use as an adjunct topical anesthetics, or using a topical formulation that we compounded using ketamine, lidocaine, amitriptyline that numbs a bit the skin. There have been some top people using some topical JAK stats that could help. I would say overall, the topical treatments are of limited value in the majority of PN patients. Another option of treatment is phototherapy, and I would say that this is a more archaic treatment. It's not so practical to bring patients 3 times a week to do phototherapy. In the era where you didn't have so many good treatments, that's an option. It was an option. The only other caveat in using it is that phototherapy in the first 2 weeks actually aggravates the itch. So again, you have to explain to the patients that they'll suffer before they'll get better. So I rarely use this treatment, but some dermatologists still like using that. And immunosuppressants were the treatments that we've been using for many years. I could say that again, they were not so impressive. They had a lot of issues of safety profile. My best drug at the time was thalidomide, a kind of a scary drug because it's a teratogenic, it causes nerve damage, but it was the most effective among the treatments. We've used also methotrexate and cyclosporin, but again, as Sean, you alluded, a lot of our patients have comorbidities, whether hypertension, diabetes, congestive heart failure with PN, and you're risking them. So I would say, and now in my armamentarium, I would say rarely I need to use any one of them, because I would say that the 2 drugs available now with an indication cover, I would say, 80 to 90% of the patients with PN. There are other drugs that we've used in the past targeting the neural system. I sometimes use it as an add-on using GABAergic drugs that reduce a bit that neural sensitization phenomena that is common in this condition, whether it's pregabalin or gabapentin, whether it is kappa opioids and mu antagonists like butorphanol. But overall, I would say that really the major difference now is that we have so good biologics, targeted, safe, that we really don't need these drugs.
In the remaining few minutes, I think we can discuss a little bit. We have the 2 approved therapies. There's also some other agents that you did a great job talking about. So how do you personally develop a treatment plan for your patients with PN and decide on initial therapy, discuss goals together? What's your approach?
Yeah, so I like this era of shared decision making. I mean, between the 2 drugs, dupilumab and nemolizumab, they're both very good. So I discuss with my patients. So I have patients who say, "Doctor, I want a rapid effect, the most rapid effect." So clearly, in this case, nemolizumab would be my number one choice. If someone is saying, I want to be sure that I've heard that Dupi is working for a long time. I know that the safety profile is extremely good. Both of them with good, safety profile. But I kind of feel more comfortable in using a drug that has been more in the market. I think that dupilumab is a good option. I would say that some patients who have PN with asthma, uh, I would be a bit careful with nemolizumab. There were some data that suggested that it could aggravate or an asthma or even initiate asthma. So in that case, I feel that dupilumab would be maybe a better choice. But overall, both drugs are extremely effective, and would love to hear what your thoughts are, Sean.
Yeah, absolutely. I love the way that you think about that. I'm very similar way talking about the benefits, the risks, the side effects of both therapies. I think it's such a blessing that they both don't require intense lab monitoring like some of these immunosuppressants that we have that are so non-specific. And you're right, comorbidity coverage can be important, especially you alluded to asthma, COPD. We know that there's an approval for COPD for dupilumab as well, and many of our prurigo nodularis patients tend to be a little bit more susceptible to that as well as a comorbidity. So it's important to ask about that always. So I think comorbidity coverage is great, but knowing that both options are, really remarkable efficacy, I think, and a huge step up. And I think it's really great that patients do have that option. And sometimes patients also want to put topical steroid ointments on there, get the intralesional injections, do the phototherapy. And sometimes we may need to, in the worst cases, add methotrexate. But I think our core is these biologics that in most cases as monotherapy, they can really get the job done and transform lives. So I would agree with you. It's really, I know for us, it's a great time seeing this and seeing our patients improve, and being a part of this change together has been one of the joys we've had. So, Gail, just a great discussion, as always, of the highest caliber. Thank you so much for joining me today. I always learn from you, and I enjoy speaking and talking with you. And thank you to our audience for participating in the program. Please continue on to answer the questions, and please complete the evaluation as well.